This conference will now be recorded.
I don't see the permission thing.
All right, we'll try it again. Now you should get a pop-up.
Well, that's the theory. Oh, it's over here. I see it. Okay, so I'm going to share.
Or I see a radiograph.
Okay, so this person has a big mass in the right base, and it looks as if it might have some cavitation in it, some gas or something like that. Let's check it out on lateral view here. Um, Here we go. You can see that there's this big thing here overlying the heart, and it seems to have some gas in it again. So it actually kind of looks like colon, which it turns out to be. So let's check it out on cross-sectional imaging here. And indeed, there's a whole lot of fat. And then we can follow the streaming of the vessels here to this anterior location. And these things are particularly well demonstrated in coronal projection here because you can see the gap in the medial diaphragm on both sides. It's fairly well centered, just slightly to the right of midline, but it's often very close to the midline here. So it's not predominantly a right-sided gap for these Morgagni hernias. But when the omental fat, which is the main constituent usually of a Morgagni hernia, it tends to go off to the right. And I think it's because the heart is held up against the anterior chest wall and sort of blocks the hernia from extending off to the left. Instead, it goes to the right, which is the path of least resistance, even though the defect is fairly medial, pretty well centered. You can see these nice vessels streaming into it. And there are some loops of colon in there as well. So they predominantly contain fat. And this one also has some colon. You can see the colon coming up here. So at this point, you can see that the defect is asymmetrical. It is more off to the right. So we shouldn't be surprised that these are always on the right. I don't think I've ever seen one on the left. So a very classic Morgagni hernia, a big one with containing not just fat, but colon. Okay. Now continuing our diaphragm theme here, if I got my things in the right order here. This person I think was a let me just check here. Yeah, this person was a donor, so a liver donor, and I'm showing you the. Let me go back to these radiographs here. Here we go. Okay, so this person had this radiograph at the time of screening for liver donation. So this is a living donor here, and the idea was to do a partial hepatectomy and then transplant that into a recipient. So this person might have, he's kind of wondering, could there be a little more Morgagni hernia going on here, but a normal, pretty normal contour of the right diaphragm out there. So she had the operation, she had the partial hepatectomy, and then this is one of her perioperative radiographs. You can see that there seems to be a little disturbance down here. We have this gut coming up fairly high. It looks as if it's still probably contained under diaphragm here. A radiograph a few weeks as she's recovering from this partial hepatectomy shows these sort of new convexities here crowding her lung on the right. Let me show you what this looks like then on CT. So we'll do the coronal CT. At this point, she has abdominal pain, and she has developed a hernia in this right hemidiaphragm containing colon, which is distended and was obstructed. You can see the vessels here in the fat and the edema in the fat here streaming through this defect. So this is an iatrogenic hernia of the right hemidiaphragm following this partial hepatectomy. And then she came to our hospital and this hernia was reduced. It was a very tricky operation. It could not be reduced from the abdomen. So thoracic surgery was standing by and they went in to the chest, and they managed to help. They enlarged the hole in the diaphragm, were able to then reduce the hernia, get everything back into the abdomen. And the colon was described as looking ischemic, but not necrotic. So they brought the colon back into the abdomen, and then they waited a few days, and then they wanted to see if it would pink up and recover, and that has been the case so far. So this was an iatrogenic complication then of partial hepatectomy. And if we scroll around here, we can see why this hemidiaphragm would be susceptible. In the past, the liver, which was complete, went all the way out to the right abdominal wall here, and it blocked omentum and colon from getting near the undersurface of the hemidiaphragm. But with this partial hepatectomy, where they removed part of the lateral aspect of the right lobe, now we have access to this. And if they nicked the diaphragm just a little bit, then abdominal pressure is ultimately going to force this fat, which is very plastic and compliant, through this defect, and colon could get in there, and then once it's in there, it could obstruct, as in this case. So this person had a serious complication of volunteering to be a partial liver donor. So let me show you a sagittal view, because it's also fairly dramatic. The very nice example of the collar sign of diaphragm here, where you have this bulging above, and sometimes you'll have a distended viscus below and a distended viscus above. In this case, we have just distended above, but we do have it flowing through this and then mushrooming above that. That's a very nice collar sign. It was a small defect. That's all it takes when you've got abdominal pressure and you've got something very moldable and plastic-like fat that can just slide right on through any sort of defect. So never volunteer, guys. That's that's what you're supposed to learn in the Army, but nobody gets, nobody has mandatory service anymore in the Army, so they don't learn that you don't want to volunteer. Okay. And then this is the result of her surgery now. This is done earlier this week. She has all these drains in place from this combined thoracic and abdominal surgical reduction of this hernia. And evidently the colon is doing fine now. She seems to be recovering. Okay, and then I would like to show you this case. This person has, on a few radiographs, you get the hint that there's an extra contour going on back here. And then on some lateral views, there's some variable abnormality posteriorly. We seem to have this convexity sort of interfering with the costophrenic angle posteriorly. On one side, we don't have a very good angle. We have not concavity, but we have a blunted angle on both sides, actually. And then let me show you what this looks like on CT. And we'll see that there's a massive amount of fat back here that looks to me as if it's sort of flowing out into the pleural space. So how are you supposed to get fat? Because there's no fat natively in the pleural space. Where did it come from? And the answer is that this person has bilateral Bochdalek, so-called Bochdalek hernias. You can see the discontinuity in the posterior hemidiaphragm here, and fat has emerged. And I presume that it has ruptured through the parietal pleura on top of the diaphragm on the thoracic side. It's probably just popped through and it's now oozed out, and it's probably free in the pleural space. And that's happened on both sides. The defect on this side is much smaller. It's medial here, very small, but you can see vessels going through that on some levels here. You can see vessels crossing that little defect. Here's a vessel right here that goes through that defect, and then into the fat behind. So we have fat that appears to be in pleural space on both sides. Let me show you this in sagittal, because I kind of wonder, is there any way that this is actually extra pleural fat, that maybe it's peeled the parietal pleura away from the top of the diaphragm and then it's come up posterior to the parietal pleura of the chest wall? There's some images where it seems to have a bulging contour here that suggests that it might be contained by something. It might have an envelope over it. It doesn't really flow out into the pleural space the way water would, the way an infusion would. On the other hand, maybe that's because it's being tethered by the vascular supply, which is coming across the defect here. So this is the defect on the right side, and let's go, is it the right or the, it's the left, and let's go across to the other side. So that's the left, and then here's the, probably a more posterior defect here on the right with all of this fat. Doesn't this look as if it could be outside the pleural space? You know,
Yeah,
chances are it's in the pleural space, but so what do you think, Jeff? I mean, does it look contained, or do you think it's just like trying to be a pleural effusion made out of fat?
no, I think it's contained outside. I mean, you show a nice continuity with the upper abdomen there, and
But what's containing it? What's the membrane over it? Because there's no peritoneum back here. These Bach-like hernias that arise medially like that, it's perinephric fat. There's no, we don't have peritoneum.
right.
It's not a
I mean,
hernia sac.
no, I guess you've got the parietal pleura sitting on top of it, but you wonder also, I don't know, maybe I'm trying to think if there's any tissue in there. Maybe that, I don't know. Maybe a very thin rim of diaphragm we can't see. It's just thinned out. I don't know.
Yeah. So it's very interesting. I mean, I looked up, Bach-like hernia and fat in pleural space and stuff like that, and I got, huge hernias, which of course do deposit everything in the pleural space, like these ones that go all the way up to the clavicle, the traditional Bach-like hernias that are very large, like in kids. So it's not surprising that they would call that in the pleura. But I couldn't find any description of this. And this is the second case I've seen with substantial amounts of fat that look as if it's in the pleural space. Let's just go back to this cross section here because I'd like to make some points about Bach-like hernia. Any posterior hernia is going to be called a Bach-like hernia. But the classical Bach-like hernia was what you see in infants. When an infant comes in with a congenital diaphragmatic hernia, it's usually on the left. It usually arises posterolateral. There's a foramen of Bach-like back there. It's one of these places where the different components of the diaphragm don't fuse that well embryologically, and it leaves a weak area. So that foramen of Bach-like is the source of the classic Bach-like hernia. It's posterolateral, sort of out here. And yet these hernias that we see in adults, and we see them with increasing frequency in age, these are clearly acquired. These are not congenital hernias, and they tend to be medial. You can see this one is very medial. So they're posteromedial. They're back in here or in here, something like this. And they're not way out in that lateral location that's the well-described Bach-like. So I have a feeling that what we're calling Bach-like hernias these days, because we're picking them up in asymptomatic older adults who are getting CT scans for other reasons. This is not really the same thing that Bach-like had in mind with the big posterolateral left hernia. Not only
Yeah.
that, the classic Bach-like hernia is almost always on the left, and these are pretty nearly equal right and left, and sometimes, as in this case, they're bilateral. So I really think it's a different entity, and it's unfortunate that it's just gotten the name Bach-like because it confuses everybody. It's really a separate thing. We should give it a different name. So I think it's Caney hernias would be good.
Yeah.
Let's go with that. Okay,
Yeah, I agree though. Yeah, we see them more and more, and with larger patients too. I think we see them more frequently.
right.
I mean, to the point where I ignore them unless they're really big and causing
Yeah,
problems, because it's like a normal variant of aging.
yeah. Okay, so there's some susceptibility back here. I don't think it has a name on it, but there's some weak area obviously that gives away in a fairly consistent way in these
Yeah,
people.
it's interesting that the lung, of course, the lungs still function just fine even with that defect.
Yeah, because it's they're not usually that big,
Hmm.
and the other thing is that, as you say, they tend to occur when you have obesity, which increases abdominal pressures to help this give
Hmm.
way. So these people are symptomatic. If they have symptoms, if they have shortness of breath, it's because of their obesity overall, and this is just one small component of obesity that
Right.
isn't that much of an additional burden. Okay, so 3 cases of diaphragm hernias.
Very nice. All right. share my whole screen here. All right, so we'll start with this case, and I apologize if I've shown this one before, but so this was an incidental finding I came across. This is the best radiograph I could find. Unfortunately, they clipped the bases, but I just want to point out that the apex of the heart is a little bit uplifted, and it looks like there's some leftward shift of the heart. We don't see the right heart border very well over midline. You can see the hilum is over the spinous interface a little bit there. Here's a scout from a CT scan that shows that a little bit better. And you can see there's this sort of lucency over here. Here's the lateral view from the radiograph. And you'll notice that the heart has a funny looking configuration. It looks kind of globus or blobus down in here. It doesn't have its normal nice pointing towards the anterior diaphragmatic insertion, and you don't have the nice apex there. So something odd with the heart. So this was I found an older contrasted CT on this patient. I think this patient had had multiple imaging for metastasis surveillance. I don't remember. This was an incidental finding. But what you'll see is indeed the apex of the heart is directed at 3 o'clock instead of its usual 1:30 or 2. And so you have to ask yourself, why is that? If we look in the lung windows, we'll see there's no volume loss. So it's not there's no real shift because of that. But what, of course, is important to look at also is what normally contains the heart, and that's the pericardium, which we should see, and we can see a little bit of it right there. It's pretty thin, but everywhere else we don't really see any pericardium. And so this is an incidental partial absence of the pericardium on the left, which is the most common. And sometimes you can see complete rotation of the heart all the way back here. It can mimic a lobectomy, but in this case, it was just partial, and the left lung just kind of hung out around it. I'll put it up on the coronal. Yeah, let me go up higher. There's that neat little finding right in here, which we don't see. Sometimes you'll see a little bit of lung come in between this recess where there's no pericardium, but in this patient, we don't see that, and I think it's because there's just a lot of mediastinal fat. But I'll put up the coronal here, and we can sometimes you'll see the lung. Yeah, you get lung underneath that can sneak in there as well. So partial absence of the pericardium. Okay, so these two cases go together. So this is a 65-year-old woman who's got some lung disease, fibrosis, but that's not her main, well, it's not helping her, but that's not what I'm showing this for. But you can see she's got pretty huge pulmonary arteries, and she has a dilated right heart. And you can see pulmonary hypertension in the setting of fibrotic lung disease, but usually it's not this severe unless they've got a secondary cause, like you can see it in systemic sclerosis. They can get independent of the lung fibrosis, but really big like this, you have to think about something else as well. And indeed, she does have a shunt that you can see very nicely here. So on this, we still have contrast coming in. We can see contrast crossing from the SVC into the left atrium. So this is an example of a sinus venosus type ASD, and those are associated almost always with some anomalous venous drainage. And we can see this little vein branch coming into the SVC right there. If we look for the superior pulmonary vein, it should be coming up there, and it's absent, so it is draining into the SVC. So you've got oxygenated blood coming into this. It should be going into the left atrium, and it can shunt across here, and this creates because the right ventricular pressures are normally lower, and right atrial pressures, you'll get preferential blood flow back into the right heart. So you get an overload, but with this pulmonary hypertension, and you can get Eisenmenger physiology, you reverse the flow and you can then shunt back this way. So now you're no longer shunting. It's oxygenated blood, but it's a volume overload. So this is just a typical case, and I'm showing this one because I came across another one that's a little bit different. And then that's this patient. So this is a 46-year-old. Who also has a shunt, and this was a coronary CT, but it shows it better. And you can see we have a pulmonary vein coming into the SVC right here, just anterior to the pulmonary artery. And the SVC itself goes into the right atrium, and you'll see that the right atrium and the left atrium are separate. We have different, slightly different mixing contrast. We don't see a jet going across this way or either way. But what we do see is a communication with the same vein that's draining into the SVC. It also drains into the left atrium. So it's in effect the same kind of shunt. It's just this little communication here, had this not been here, this would have been normal drainage in this patient, but it created a shunt, and we can see the denser contrast coming into the SVC. So this is sort of, I call this a variant sinus venosus type ASD, but the sinus venosus itself is technically intact. So it's just partial anomalous venous drainage with a little tiny communication there. So I'd not seen this variant of it before. I don't know if it has a specific name. I'm not sure, David, if you've ever come across it, but I would just classify it as a variant sinus venosus ASD with partial anomalous venous drainage.
It's very cool. I've not seen it before.
Yeah. And so this actually, they actually repaired this. They just ligated this, and that solved the problem. There were some other issues with it as well, but you can see everything else. There's no other anomalies with it. So two sinus venosus type ASDs. This is another neat pulmonary vascular case. So this lady is 56, and you can see she has already abnormal vasculature. So we can see the right brachiocephalic is very thickened with a narrow lumen. Same with the left common carotid. We don't even see really any contrast there. It kind of fades out. And then the left subclavian artery is also thickened. So this looks like large vessel disease. There's a lot of motion on this scan. Unfortunately, it was done somewhere else, but I think you can still read through it and realize there's probably something wrong with the aorta itself. And then also the pulmonary arteries. Even though we have motion artifact, you can see that the branch pulmonary arteries are narrow. There's almost certainly some wall thickening there. And if we follow the left pulmonary artery down, we can see we sort of lose the lumen caliber is too small to be a basal pulmonary artery. And there is some soft tissue around it. Compare it to the other side, this is the more normal caliber. And then in the basal segment here, it's pretty small, very little flow. The lingular artery, which we should be seeing about here, is out. And then the anterior upper lobe, we see there's really just a little bit of contrast getting into the apical segment, but the anterior segment is out. Here's a VQ scan. So ventilation on the top and third rows, and then the brighter one is the perfusion. And you can see that sizable defect in the left base. Interesting, there's a little bit of ventilatory variant, but there is quite a perfusion deficit predominantly on that left. But you also see the apex of the right upper lobe is involved as well. So that corresponds with that. So this patient, so large vessel vasculitis in a 50-something-year-old, you would think of giant cell, but this is actually Takayasu. This is a long-standing process. I don't have more ancient imaging, but usually it's diagnosed before the age of 30. But I've seen some older patients with it. It's just kind of because it's a chronic disease. So she got some treatment with it, and this is a more recent scan, and there's going to be a lot of improvement. So we can see that there's still some narrowing of the brachiocephalic. The subclavian looks a lot happier. The aorta looks a lot happier. And the pulmonary arteries are narrowed. This is a better scan. We don't have as much motion, but you can see there's irregularity of this left pulmonary artery. Almost looks, you don't see interluminal abnormalities, but you could mistakenly think this is CTEPH or CTED because there are some sort of stenoses. And if we go down here, we can see there's not a lot of, they're very small basilar segment arteries. And that lingular artery is still out. It should be right here going right by the bronchus, and it's not there. It's occluded. And that right upper lobe pulmonary artery is still very small. There's a posterior branch coming up. The anterior apical branch is patent, but that anterior branch, which should be right here, is out. So Takayasu arteritis affecting the pulmonary arteries and the systemic large arteries in a slightly older patient. So except where we saw some improvement, but some of this is more chronic. But if you just had this scan, you could potentially end up calling this incorrectly chronic PE with some occlusions. And of course, the treatment would be very different. But we would not expect somebody with Takayasu to present at this age. But giant cell arteritis could absolutely present at this age. You could also consider Behçet disease, but it's rare in the US. And pulmonary arterial involvement is usually limited to male patients. Okay,
So,
and
Jeff,
yeah,
you said that she was diagnosed before the age of 30, right? So this is just,
I don't know, but it was a while ago. I don't have all her imaging, but she established care with us several years ago.
got
So
it.
I only have imaging in the sort of middle age time period, but presumably she's had it for a long time. And that may be why those lower lobes are out and didn't respond to therapy. But I didn't have anything from like 20 years ago to compare with. Yeah, because all the other cases I've seen are usually teenagers, young adults. I've seen a couple cases in male patients. It's much less common that it does occur. All righty, well that is what I have for this week, and I don't think anyone else was able to join us. So thank you very much, David, for the diaphragm tour, and we'll have to come up with a new name for that hernia.
Okay. Okay. So, Jeff, I'll be out for the next 3 weeks. So
Okay.
away. So